Thank you everybody for coming out tonight, and we have a kind of a special seminar, and the Board of Health has really spearheaded this and trying to get information out to the public of the town of Carlisle. We have Mark Nascarilla and we have Nicole Daniels tonight, and they're going to be talking about exposure of naturally occurring metals and private well water.
So, just to echo Todd's comments, on behalf of the Commonwealth and the Department of Public Health, I want to thank you all for, one, inviting the Department of Public Health here to have this conversation with you, and for taking the time out of all of your schedules to be engaged in this process of feeding back information to the department on ways we can better support your community and the needs around drinking water and resources the department might be able to make available. I noticed coming in that this meeting was described as a biomonitoring meeting, and we'll certainly be talking about that. But I want to preface it by first having a conversation about drinking water in the area. I think there has been some concerns presented to us about drinking water. And so we thought we'd start by just walking through what we know about drinking water in the Commonwealth in general, how it's regulated and things like that. And then step into a conversation about our biomonitoring study. So I'm the chief toxicologist at the Department of Public Health. I'm a PhD trained scientist, so I'm a doctor, but I usually come to these meetings and say I'm not the kind of doctor that can make you better. I'm usually the doctor that makes you sick when you hear those things. So I don't diagnose or treat any conditions. I can't give you medical advice about any conditions. Really what we're doing in the Commonwealth and the Department of Public Health is conducting public health surveillance to understand what potential impacts might be from environmental exposure. So I don't want you to leave this room thinking that the department is here because we think there's some real medical concerns in the community. I often say when people call me, if it's an emergency and you're calling me, you're calling the wrong number. I don't do emergency response. I help individuals understand exposure to environmental chemicals. That's one of the things I do. One of the things that I'm fortunate to be able to do is work with Nicole Daniels, my colleague who's here. And Nicole works exclusively on the biomonitoring project. And Nicole is here to help address any questions you have at the end of this presentation about biomonitoring. And together we can maybe address any specific concerns. So I thought what we do is I put together some slides that I'll walk through to kind of frame up what we think are the issues. At the end, I'm happy to take any questions you have, but I'd say if you have specific questions about a medical condition or a condition specific to you in your home, maybe approach Nicole and I separately, or provide your name to Nicole and we'll do some follow-up. Usually it's not a good idea for us in the health department to have that kind of a conversation in an open setting. There might be information you want to share with us, and we're happy to do that. We work for you, so feel free to take full advantage of that and contact us for any assistance you need. The system works best when health departments reach out to the state health department and request our assistance. So we're very happy to provide that to Carlisle and hope you take advantage of it. So, first we'll step through a little bit on exposure to environmental chemicals. I realize from doing these public meetings, and we do them quite often, is that environmental contamination can be a very emotional concern. And so I want to recognize that and talk through how individuals are exposed to chemicals, not just here in Carlisle, but everywhere. What we know about metals in private wells in central and northeastern Massachusetts, again, not just Carlisle, environmental contamination really knows no municipal boundaries. It's not something specific to your community. There's nothing wrong with Carlisle, and actually driving here, Nicole and I were both like, this is a really beautiful community. It really is a great town. So I don't want you to think this is anyone is impugning this community. But there was a USGS, United States Geological Survey, study of arsenic and uranium in the area, and you all should be aware of it. We do have a Department of Public Health has a biomonitoring study, and I'd like to talk to you about that. And we have some other helpful resources that I think you'd benefit from knowing about. And then there's a very specific study, the Biomonitoring Massachusetts study, that we can talk about. So environmental chemicals are present in virtually every media we're exposed to, including arsenic and uranium. They're naturally in the environment, they're naturally in the food we eat, they're naturally in the water we drink. They're at what the government considers permissible levels. So there are levels of safe exposure to these contaminants. So you find them in virtually anything. There's oftentimes a misconception that certain things are chemical free. And usually that's just not the case. We don't live in a chemical-free environment, and actually we can all live and breathe in areas with low levels of environmental contamination or environmental chemicals that are present, and we do quite well. People are exposed to low levels every day, primarily in food and air and the water that we drink. That's very common routes of exposure. It's not unusual for individuals to have levels of any one of these chemicals in their body. We've been doing a study in all of Massachusetts across the entire Commonwealth for about 4 years now, where we're collecting baseline information on levels of chemicals inside people's bodies. It's not specific to Carlisle that we would identify chemicals. We see it across the whole Commonwealth. And I can tell you that when the Centers for Disease Control, CDC, does studies across the entire country, they see very similar things. They see that low levels are present in people from around the country. Measurement of these low levels, having environmental chemicals in your blood, is not the same as saying those environmental chemicals can potentially cause harm. And that's a difficult concept for all of us, and I'm always reiterating that, even with the policymakers and folks that make the decisions at the health department. I think it's because we are all primed to think, when you take your kids or when you go to the doctor's office and you have that strep test, right, that they're running in the lab, and you get a strep positive result. That is a positive indication that you have strep in your body, right? There's an actionable medical intervention, something you can do to treat that. When you get biomonitoring results back, when someone's measuring chemicals in your body, it's neither good nor bad. It's just a description of the chemicals in your body. There are levels that are unusual. So we can measure levels in people and say, that is not typical of what we would see if we sampled, say, 100 people from the United States. You would be unlike 95% of those people. So we can say those kind of things, and we can say that this is how you're potentially exposed, and these are ways you can reduce exposure. But what we can't say is, based on this test, we now expect this. Like the strep test, where you can say, this test came back positive, you have strep throat, right? And they give you some treatment for it. This kind of test doesn't answer that kind of question. How do people become exposed to chemicals? Many times it's through housing and location. You know, you have a beautiful etched sign as you walk into this building that says this town was incorporated first as a district and then a town a very long time ago. That means folks were building homes in Carlisle at a time when folks were still using lead in paint. And paint deteriorates, and children mouth surfaces with paint, and they're potentially exposed to things like lead through paint in homes, or older housing stock has other metals in it where you're potentially exposed to a lot of different chemicals. So housing in certain locations tend to have more chemicals. Different hobbies and activities, kids playing in contaminated soil or soil with elevated levels of metal can potentially be exposed to heavy metals. Different behaviors like smoking. Smoking contributes to a great deal of chemical exposures. Diet, eating certain foods like fish can potentially expose you to things like mercury. I think we've all heard that and know that. Your occupation, if you tend to work in the trades and work with metals, or you work in the automotive industry and you're around rebuilding engines a fair amount, all that's associated with different chemical exposures. And drinking water is, of course, a primary source of exposure. So private wells. Carlisle is a community where the majority of folks in this town are on a private well. In some communities in Massachusetts, there are public water systems. So what that generally means is in those public water systems, as you likely all know, somebody else is taking the effort of testing the water, providing the water into your home, handling the distribution system. So someone else is testing the water and ensuring the water's safety. When you have a private well that is serving your own home, it's the responsibility of the homeowner or the private association, who's ever maintaining that, to ensure that that well is not vulnerable to contamination from both human and naturally occurring sources. Your health department oftentimes will work with communities to understand that. In Massachusetts, private wells are regulated at the local level. The health department, the Massachusetts Department of Health, where Nicole and I are from, what we're representing here, we don't regulate public water, period. So public water systems, I live in the city of Boston, Boston's public water is from MWRA, which is actually sourced from the Quabbin Reservoir. And that MWRA, our public water supplier, is regulated by the Department of Environmental Protection, a different agency. But the Department of Environmental Protection doesn't regulate homeowners. They don't regulate private wells. That's been delegated to the local level. The recommendations from the Department of Environmental Protection, if you have a home well, then have it tested. Have it tested for certain contaminants, and they make recommendations on what to test for and how to test it. That's because some areas of New England contain higher levels of naturally occurring metals, specifically uranium and arsenic. We happen to live in an area of the country where there's underlying bedrock. There's a seam that goes through Massachusetts up into New Hampshire that has naturally occurring levels of heavy metals. So the recommendation for anybody on a private well in Massachusetts, especially in those areas, is to have their water tested to ensure that that water meets what a public water system would be required to maintain, essentially safe levels of contaminants in water. So what can these potential contaminants do? The question that's often posed to us is, what does it mean if I've been exposed to uranium and inorganic arsenic? So uranium is generally associated with uranium in water. The risks of that are from the chemical toxicity. And what I mean by that, when we hear uranium, most of us think energy plants, nuclear energy. We think of the radioactive or energetic properties of uranium. That's not what we're talking about here. Generally, we're talking about uranium and its ability to cause a chemical risk, not a radioactive risk. Uranium has certain metallic properties, chemical properties that makes it a chemical much like lead or cadmium or mercury. It has these chemical properties that make it potentially dangerous. Radiation risks are very low from uranium. Uranium's a really hard metal. It's actually used a fair amount in military applications to shield armor in tanks and things like that. It prevents armor-piercing rounds. It can prevent lead bullets from going through it. So it's really strong. So it tends to be really persistent in the environment because it's such a strong metal. We generally don't see radiation risks from that kind of exposure to uranium. And no human cancers have been associated with this kind of chemical risks. So we're not talking about those kind of risks. The primary target of uranium toxicity is really the kidney as well as bone and soft tissues. Inorganic arsenic, and arsenic's a bit complicated, and we'll talk about it here in a little bit, because not all arsenic is created equal. There are different kinds of arsenic. There's inorganic arsenic, there's organic arsenic. The kind of arsenic that might naturally be in your seafood is organic arsenic or arsenicals that are essentially safe. That's the arsenic that's not dangerous at higher levels. Inorganic arsenic is a different kind of arsenic, and that's the one that potentially is present in bedrock. And it can cause gastrointestinal effects, some stomach effects, a number of other different effects, including anemia, cardiovascular effects, etc. We oftentimes describe these different effects because, one, they've been identified in animal studies at relatively high levels of exposure. But I want to caution you that because these health effects are associated with these metals, it doesn't, one, mean that they're likely, or two, mean that they're present at what we call environmentally relevant concentrations, the kind of low levels you see in water. Generally, these health effects are associated with higher levels of exposure. I don't know your levels of exposure. I don't know the levels of the contaminants in your water. What we have seen from previous studies is the levels of exposure are not acutely toxic. They're not really high levels that are associated with the kind of studies that showed these effects. So oftentimes it's a bit of a delicate message. We always want to be over conservative. We want to be health protective when developing these standards. So if we see things like really high levels of exposure in an occupational setting, and somebody might develop anemia or a severe neurological condition, we want to make sure we recognize that and make sure that doesn't happen. But it doesn't mean that everybody exposed to that metal or that exposure, that's going to happen to them. So just want to make that clear. So there has been a study of private wells in central and northeastern Massachusetts. This was a collaborative effort conducted by the federal government, the United States Geological Survey, as well as the water regulator here in Massachusetts, the Massachusetts Department of Environmental Protection. USGS offered private well testing to folks that lived generally within that band. And you all know where Carlisle falls in that band, and you can see it is on the outskirts of that area. So Carlisle was generally included in this study. The Department of Public Health offered urine testing to a certain subset of residents that lived in that area to try to understand what their arsenic levels in their urine was. Urine testing was provided to folks that consented to participating in the study. So not everybody in that area had their urine tested. There was a certain number of individuals that elected to participate. All of this information is available online. This report, a full version, is available on a website that, if you're not aware of it, I can certainly make it available to your health department, as along with these maps. All this maps of where the levels of arsenic have been measured in bedrock and private wells in Massachusetts. That's available on the website as well. So what did the Department of Public Health, how did they get involved in this, what I'll call the first biomonitoring project? Likely not the one a separate one that's ongoing right now. This was a separate study that was prioritized or targeted for communities that rely on private wells only. All participants participated in this USGS water testing study. So the recruitment was from folks that had their private wells tested within the home. 37 out of 144 individuals accepted the offer to provide a urine sample to the department. So I want to take a step back. Some of you might be saying, well, what is biomonitoring? I saw the sign out front. Why would someone provide a urine sample? So biological monitoring, or biomonitoring, is a way to measure in somebody's body a level of an environmental chemical. Typically, what we consider in the federal government, CDC considers the gold standard, is really blood and urine. When you're testing an environmental chemical in blood and urine, you get a great deal of information on how the chemical moves through the body. Some of you may be familiar with, and you may actually work in fields where this is required. You can measure these things in a lot of different ways. You can measure it in hair. I often say that wouldn't be all that effective when, if I was being assayed for it. You can measure it in nails. You can measure it in a bunch of different ways. Why we always point folks to urine and blood is a lot of people measure chemicals in urine and blood. So it gives you an enormous database to compare individuals to. The federal government conducts a study on a cycle of every 2 years. They sample folks representative of the entire United States to measure chemicals in blood, in urine, and we use those as a comparison. We say, when we conduct this study, how do those compare to everyone else in the country? We can compare it to other people around the world. So if we're measuring somebody that's from a Central Asian country and they're a recent immigrant or refugee to this country, we can look to see, well, what are they doing in Central Asia around there? What do those folks look like? And then have some kind of a comparison. When you choose blood or urine, you get the greatest probability of selecting a media that you can evaluate. So that's why we use blood and urine. They can only tell us if a chemical is present in blood and urine, and we can characterize the level, how you compare to some of those other individuals. It tells us nothing about how you were exposed. So an individual with arsenic in their blood, usually not tested in blood for a lot of different reasons, but usually people with arsenic in their urine, it doesn't tell us where that arsenic came from. So if somebody has high levels of arsenic, it could be from the food, it could be from the water, it could be from an occupational source. Same thing is true of lead. If we measure lead in their body, we're not really sure where it's from, so we can never say definitively when we conduct biomonitoring, it's from a private well or it's from the food you ate. It becomes challenging. Each analyte, each chemical has its own challenge. When we measure arsenic in somebody, we don't know definitively if that arsenic is from something like a fish meal. Folks that eat a lot of fish tend to have higher levels of arsenic because they have a lot of these organic arsenicals in their body and potentially exposed to other arsenic. Folks that eat a lot of fish tend to have higher levels of mercury as well. A lot of Asian populations that eat rice that's been imported from regions where it's grown in rice paddies where there's high levels of arsenic also have high levels of arsenic in their body. So we never know when measuring somebody where that comes from. So that's an important distinction as well. So it can show if a person has been exposed to a chemical, and it's helpful to know how that compares to what's normal and abnormal. So this biomarker, this marker in the body is really just a biomarker of exposure. It says if you've been exposed to the chemical. It's really a snapshot in time. If we collect what I'll call a spot collected sample, if you all provided specimens today, that's really only reflective of your exposure over the last few days, right? It's not an integrated assessment. It doesn't tell me anything about your exposure a year ago or 2 years ago. We're not able to do that kind of an assessment. But it says, based on a snapshot at this specific time, this is what we think you're exposed to. It doesn't tell us the total amount in your body, and it doesn't tell us if your level would be any different 2 days from now. So if I took your sample today and you recently ate some fish, it might be reflective of that, but that might not be typical of what's in your body all the time. One of the, in biomonitoring results certainly don't tell us anything about the specific timing or source of exposure. One of the reasons we're conducting a biomonitoring study across the state is we're really trying to understand the health of the Commonwealth, the entire state. It's not a study designed to specifically diagnose or treat individuals. So when we identify an individual with a high level of a chemical in the body, we provide that information to them, ways they can reduce exposure, but it's not an indication that an adverse event is likely. It's not the report you get from your doctor where you say you have strep throat. So this is a bit of there's a lot on this slide. I've used it to actually teach graduate students before, and I know it's a tricky slide to get through. But what I want to, the point I want to make with this group is, if we think of biomonitoring as a continuum from beginning to end of how we're trying to protect public health. I want to draw your attention to this first box, sort of indoor coal burning, for example. And many of you might have coal burning stoves. If there is coal burning in your home and you have poor ventilation, you might have high levels of heavy metals in your home that you're potentially exposed to. So things like coal ash have high levels of cadmium and other heavy metals. So if your home had really poor exhaust, and we see this a lot in underdeveloped countries where they burn a lot of things indoors and they don't vent the smoke properly, they have really high levels of exposure. That exposure would lead to someone inhaling a lot of dust, and we'd be able to measure it in their urine in that middle box. And that's really why we do biomonitoring. We're trying to understand where the exposures are at that point. Because the next thing that happens is those levels of exposure are high enough to cause something to happen. We call that an effect, a biological effect. So someone might measure a kidney protein that's elevated, and this might have happened to all of you. You're at your routine well visit with your doctor and you have your clinical chemistry test where they're drawing some blood and drawing some urine, and they notice something's a little off, an enzyme's off, or this is off, or that's off, and they schedule you for some additional testing. That's a way to catch something before you presenting to your doctor saying, oh, my pancreas really hurts, my kidney hurts, I'm really having trouble standing. They're doing that routine visit to try to catch that before it happens. That's why we do biomonitoring within populations, to look at populations and try to catch it before it happens, catch it before it leads to a true health impact. And that's essentially why we're conducting biomonitoring. The difficulty of that is when conducting it, when we're measuring levels in urine and we're conducting biomonitoring, it doesn't tell us if it will ever lead to that health impact or if that is the likely cause of any health condition that might currently exist. So that's the real difficulty. So arsenic and uranium are excreted in urine samples, generally within a few days of exposure. So it's critical to collect urine samples, usually during well water use prior to changes in behavior. So if we're doing a study in this community to understand how drinking water exposure, drinking water potentially with high levels of arsenic might contribute to all of to a community's levels in their urine, it's important to conduct that study before individuals stop drinking the water. So we wouldn't be able to, if an individual had stopped consuming water because of potential levels of a metal in their water, and then 3 months later conduct a biomonitoring study, that may not tell you or give you the information you're looking for. Just because the arsenic and uranium are excreted really within a few days of exposure, and it won't tell you if you were previously exposed to it. It's not something where you're going to be able to measure really low levels and we know it was there in your water 3 months ago or a year ago. We collaborated with USGS in the previous study to mail urine testing close to the time of water sampling in that study. So folks were sampling their water, and then we were also collecting a urine specimen from that participant. So we sort of had some paired results in that previous study. And then we offered additional urine sampling after the USGS went out into the community and shared the results. Again, all that information is available online, but in a few slides I'll go into our current study, and I don't want you to confuse the two. They're kind of separate studies. So some of the findings from that project, and for some of you I'll save you the trouble from having to find that report and read through it and all that. Some participants had arsenic or uranium in their private wells above standards for public water supplies. In other words, if arsenic and uranium were being measured in that water and it was a public water system, DEP, the regulator of water in the Commonwealth, would say, you have to treat that water. You have to get it below these standards. The urine results were compared to national data. The NHANES study, it's a national study that CDC conducts routinely on a 2-year cycle. And those urine results were compared to these nationally representative levels. None of the 37 participants in that decided to enroll in that study had levels of arsenic or uranium in their urine above the NHANES level. So none of those participants that were on that water had levels that exceed the 95th percentile. Some participants had arsenic and uranium in their urine, and it was higher than the general population. We routinely see that. So there were folks where we measured arsenic and uranium in their urine, and we said, well, that's higher than the typical level you'd see all over the country. But we would have expected that. And as I said, we would expect to see arsenic and uranium in anybody, including folks like me that live in the city of Boston, and we're drinking a water supply that doesn't have arsenic, doesn't have uranium, just because it's present in the food we eat. And if I come out here and stop at the farm stand out here or eat some Kimball's ice cream or something like that, I'm exposed to the food that's potentially sourced in the same region you all are consuming food from. And that's how other folks are potentially exposed to regional chemicals. The private well results in that book that's available online are based on samples from 478 private wells. They were all bedrock wells in 116 cities and towns. 13% of those samples exceeded the arsenic standard, and 3.5% of those exceeded the drinking water standard. So that's what they observed. I also want to point out, as I mentioned earlier, we set these standards. We, regulatory toxicologists, develop these standards to be overly conservative. It's not a bright line. In other words, if the standard is 10 micrograms per liter and you measure in a sample 11 micrograms per liter, no one is able to say that for what adverse health effects are likely, or that short-term exposure to that kind of exceedance would lead to an adverse health effect. The way these standards are developed is they are levels that are safe for a lifetime of exposure. So that's the level of arsenic, or that's the level of uranium that you could drink for literally 70 years, every day, 2 liters of water a day, and it would still be safe. So when we as risk assessors look at that and we say, somebody stepped over the line, right? It's a bright line, someone stepped over the line, the water is no longer 10 micrograms per liter, we say, well, what's going to be done about it and in what time frame? And what dictates what's going to be done in what time frame is how high is it? So if it's 11, we tell the community, you should fix that, and you should fix it soon, within a short period of time, a month, 2 months, whatever the corrective action period is. If it's 100,000, it's shut off your water immediately and offer private water to folks. So there's a difference between the two. Just stepping over that line doesn't mean that the water is unsafe. It means that it's not safe for 70 years of exposure, 2 liters of water a day for your entire life. And then the wiggle room there, so to speak, is how high is that water. So some helpful resources that are available online that will explain in detail this study. We have what we call a FAQ type document. It identifies frequently asked questions that are posed to the department about this study and go through some little narrative response on answering that specific question. There are all sorts of maps and layers. If you happen to be the type of person that can use those computer programs, like a GIS person, you can actually get these maps, these layers, to do some analysis of your own. It's all available online, and it's available to all of you. So a little bit about the biomonitoring study that we're currently conducting. So this is a study that there are five grantees in the United States. Massachusetts is fortunate to have one of these grants. There's 3 other states, and us, that's 4, and then those four states that are connected combined on one grant. So there's 5 folks doing it. Here in Massachusetts, it's a joint effort between my team and the environmental toxicology program, and then our samples are analyzed by the chemists, the scientists at the State Public Health Laboratory in Jamaica Plain. So we collaborate on this study, and the study has several different goals, or buckets, if you will. We always refer to these as what we're trying to accomplish. The first is this statewide study. We're conducting a study throughout the entire Commonwealth, trying to approach as many of the 351 cities and towns that we can to collect a representative sample of adults. So to collect a sample in Massachusetts that looks like the demographics of Massachusetts, the same age, race, ethnicity, gender, and collect a representative sample of that group and measure levels of environmental chemicals in their blood and their urine, so that we know what Massachusetts as a state looks like compared to the rest of the country. We're also targeting certain high-risk communities. We're specifically targeting certain areas where children between the ages of 5 and 12 and women of childbearing age between the ages of 15 and 49 years old. High-risk communities can be defined a number of different ways. Perhaps one of the most important to the Commonwealth, and really informs some of these ages, and is areas in Massachusetts that have either a low screening rate on childhood lead poisoning prevention. So those of you with children know that you're required by law during a well visit to have your child screened for a blood lead at least 3 times. Unless you live in an area where greater than a certain percentage of the population the children are coming back with high blood leads, then we require you to do it 4 times. So those areas, children are screened between 0 and 5. Unfortunately, a lot of those areas, they're in the most underserved areas of Massachusetts, some of the gateway communities. They welcome a lot of refugee immigrant populations. The kids come into those communities at 5 years old, a lot of times, to start school, and they're never screened for heavy metals. So we're really targeting those areas to capture those kids, their families, and understand what their exposure to specific contaminants are. Things like lead, mercury, PCBs, the most potent and most dangerous. And then the third area of our study is really in response to accidental chemical exposures or site-related concerns. So we have, as part of our goal to support ongoing emergency response, believe it or not, there's a number of different doctor's offices here in Massachusetts where they still use mercury equipment, and occasionally that equipment breaks, and or they still use mercury in classrooms, jars of mercury, and if that mercury spills and potentially children, faculty, and staff are exposed to mercury vapors, we offer the response of our team to go into the community, collect urine, try to understand to what extent that community was exposed to mercury, and offer some opportunities to kind of remediate the situation or offer some helpful information. So that is something that's also available to this community. You have some knowledge of it now. Should there be a town building here where there's a potential mercury spill, we have that service to offer you. And occasionally we offer it. One of the other hats that I wear is to support the federal government at contaminated waste sites in Massachusetts through a cooperative agreement with federal toxicologists, the Agency for Toxic Substances and Disease Registry. So if there's a contaminated site in Massachusetts where there's concerns around that site from community members that might be exposed to chemicals migrating off that site through fugitive dust or other ways, we offer a biomonitoring to help address that community's concerns about potentially lead or cadmium migrating off that site. So what do we look at? For the statewide, we call these our panels. The statewide metals that we look at are, we look at manganese in blood, we look at PCBs in serum. In blood is kind of split up into different components. Generally, those are both blood. Serum and whole blood are a little different. And then urine, we look at a number of different things. And many folks ask, why do you look at all those analytes, those chemicals specifically? And my response usually is because we can. Because the machine that measures those, when you run the urine through the machine, it can measure those things specifically, and you can set it up to do that. So we say, well, let's just get all that information. The targeted chemicals, those are the ones we're most worried with. Cadmium, lead, manganese, and mercury, we measure that in the blood in these targeted communities, the high-risk communities. And in urine, we measure cadmium, lead, manganese, and mercury as well. Why those specifically? Those are considered very potent, very dangerous chemicals, and those chemicals actually have what's referred to as medical intervention guidance, clinical intervention guidance. So if somebody has a high level of lead, there's a definite clinical step you can take. If someone has a high level of cadmium, there's a definite clinical step you can take. So that information becomes very useful to somebody. For a lot of chemicals, we just don't have a lot of information on if the exposure is really high, what's the medical intervention? What would a physician recommend? It's a little more complicated. So we're really conducting that statewide study to help develop that information, collect that, to help inform those kind of questions. And again, for the episodic exposures, this response, we can offer any one of these analytes. So if it's a site that happens to have really high levels of tungsten, tungsten's often used in military applications. So if it's an old site that used to make cannons or something, and individuals are concerned about tungsten in soil, and there's been a child eating a lot of soil, we could say, well, we can help out with measuring tungsten levels in that child to help understand if he or she was exposed to high levels of tungsten. So this is the end of the slide deck. It's important that, one, I acknowledge the funding that the Centers for Disease Control provides, allows Nicole and I to be here to a great extent. And generally these views reflect my own views and not that of the department or the federal government. And my contact information is here. I'm happy to take any questions you have. I will say if it's about a specific medical condition or there's information you want to share with Nicole or I after this meeting, we're happy to take your questions one-on-one. You can also contact me or contact the Biomonitoring Massachusetts study team directly. We treat your request as confidential. It's protected health information. But other than that, I'll open it up to questions that you want to ask.
So you talked about having your well tested and all that. How often?
It's a good question. I think generally what we recommend is yearly. Sometimes there's, and it depends on a lot of different things. Yearly is what the Department of Environmental Protection will recommend. If you have a database of say every November you're collecting information on your well and you're noticing there are no changes, every year, seasonally, you might be able to switch to every year and a half or something like that. But good guidance is at least year. Why do we say yearly? Because as I mentioned, these standards are set up to be chronic levels of exposure, right? Levels that are safe for a lifetime of exposure, 70 years, 2 liters a day. If you're checking it at least every year, checking the temperature, it's like your well visit with your doctor, a little checkup on your water. If you notice something going up, it's an opportunity to explore why that happened and correct it before it gets really high and you've been exposed to multiple years.
You mentioned New Year, November. That's just a random month, I'm sure. But
Yeah.
would these things you're testing for vary seasonally?
They could, and where they would vary the most is potentially seasonally, but if you recall 2 years ago, and many of us will, especially this community where a lot of you are in private wells, drought. So when there's not a lot of rain, if you have a well that's potentially recharged by a lot of surface water, and you see the volume go up and down with rain conditions, that's a reason to be checking your well a little more frequently. As the water level in a well goes down, if there's a lot of contaminants in there, the contaminant levels will go up, right? It'll get more concentrated in your well. So generally every year, however, if it was like the summer we had 2 years ago and we didn't have enough water pressure for fire suppression, we had trouble getting hydrants with enough water, that's a reason to say, I need to check my well, see what's going on. Yes?
Just to add on to what Lee was saying, can you talk a little bit about what kind of tests you want to have done? For example, with our home, we had our water tested, but we didn't go through the Board of Health. We just had our water tested and everything was fine. But it turned out that we never had the metals tested,
Sure.
which was...
Sure, it's a great question, and it's a complicated one, right? Like when ordering the test, you don't, it's not like fast food where you're ordering off the menu. It's complicated because there's a bunch of analytes that you can order. A couple things I'll say is, one, the Department of Environmental Protection has a website with certified drinking water laboratories. Use one of those. Use a laboratory that the Department of Environmental Protection has said, this is a laboratory that they have certified as being able to do drinking water. That's for a couple reasons. One, they verified that they're actually running methods, they're conducting tests the way they should be. And two, they're putting their stamp on the fact that they're not a consultant. You don't want someone testing your water that they're testing your water and they also say, and I got this great treatment systems for water systems and your water's not looking great. But let me tell you about, that's a predatory practice. It's illegal. If you're aware of folks doing that, please let us know. But there's a list of labs that don't do that. The Department of Environmental Protection has the methodology you should use to collect your water. There's a certain way to collect it, and they have the recommended tests. So the recommended tests, and that's a great question, I would recommend using the same ones that the public water systems use to test their water. And I think that's a good standard. It might be that some of those become cost prohibitive. And I think that's a conversation that the drinking water program at the Department of Environmental Protection could have with you. Because what you might be able to do is on a yearly basis, every other year have one of the expensive tests done. But in general, there's a standard panel you should use. I don't have it committed to memory, but there are certainly metals on that list that you should be testing regularly. Yes?
You showed a number of elements that are routinely done. And I think you mentioned that that's done because those are elements that you can conveniently
Yes.
have done by the chemistry.
Yes, and to be clear, those were chemicals in urine and blood for the biomonitoring study, but not in water.
Okay, but that doesn't include some elements that may be even more pernicious to the human body than those elements. I don't know what the cost of these analyses are. Roughly, what are they? What is the cost of?
For which ones? If you were
For
testing a
those elements that
biological
you
specimen?
included.
So for each one of those, generally speaking, if you were to go to your physician and they order the test and you paid for it out of pocket, it would range from anywhere from $500 to $1,000. You're correct in that the chemicals that the Department of Public Health is testing in individual blood and urine samples is not an exhaustive list of every potentially dangerous chemical. And some of those chemicals are not ones that would be routinely tested for in blood or urine.
Some analyses that are done, total analyses that are done in some reputable laboratories, can be done for about $150. And that would include major elements and virtually all of the elements, most of the elements of importance in the periodic chart.
Now, are you, so I'm not-
ICP-MS and mass spec analysis. App Labs in Canada does that all the time.
So I think you're referring, I just want to clarify, and that when I showed this slide, what I was referring to is blood and urine samples, not
Yep.
water samples. So These, it's different, and I know it is confusing to have this conversation along with water testing. But in general, when we test an individual's blood or urine for these chemicals, we do it in a certain way, a very prescriptive way, in a manner at our state laboratory that's very similar to how a doctor's office would test it. It's a prescribed procedure. So I was comparing the costs of this test to a doctor's office. When you say that measuring these chemicals in a laboratory, in a water sample, can be done, and it can be done for X or Y dollars.
Anything. Huh?
Yeah.
Why can't you send in a sample of blood anywhere?
It's
And
yeah,
have
it's,
that analyzed.
yeah, it's just different. You know, sometimes when a chemical is in what they call a different matrix, when a chemical is in water or when a chemical is in blood, the chemical binds that matrix a little differently. One thing I'm working with the department in the Commonwealth on a lot. Never thought I'd be doing this when I was going to graduate school. I advised the Commonwealth on testing of marijuana for contaminants because it's all the rage. One thing we've realized is marijuana is one of the most difficult substances to measure chemicals in because everything is different. It just binds the chemical differently. So a test for water really isn't comparable for a test for blood or a test for food or a test for this. It's kind of an apples and orange comparison.
That's interesting. But that could require some further discussion.
You betcha. Yes.
I was interested in your comments about uranium
Here's stuff.
because it turned out that we, without realizing it, have a very high level of radon in our water supply. And it's actually was like 90,000 picocuries per liter, which I believe is like, it's supposed to be less than 4,000, I think. I'm
Wow.
not sure exactly what the
Yep.
recommended level is, but it was hugely elevated. So now we have a treatment system, which requires the water to be basically purged with air in a big tank, and then the radon goes into the air and it's vented out through
Yeah.
a pipe.
Mhm.
But my question is, you're talking about uranium, but is there a correlation between uranium level and the radon content?
Sure.
In which case, they never mention testing for uranium, I don't believe, in the
That's
water.
the
supply.
radium.
Huh?
That's the radar.
Oh, it is the radon.
No,
No, it's the uranium.
you're right. It's very complicated. Uranium and radon are two different things. And when folks are having radon tested, you really are evaluating it. The units that you described are units to be protective of radiation risks.
Yes.
Right? The uranium that we're measuring in individuals when we measure the metal in their water or the metal in their body is a different substance. But you're right in that it's like smoke and fire, right? Where there's smoke, there's likely fire,
Right.
and it's wise to have. That's a general recommendation for anybody that lives in an area where the bedrock is known to contain radon to have their home tested for radon. So I did not mean to imply that anyone should be dismissive of radiation risks from radon. What I was more trying to imply is that don't ascribe uranium to only a radiation risk or having the metal itself has a chemical toxicity. So in other words,
Yes, but the source of that radon, I think, is uranium
It
in
is.
the bed, in the rock. That's what that was
In
told.
Carlisle, it's thorium.
I'm sorry?
It's thorium, orders of magnitude over
Well, I
uranium,
was told it's uranium.
also giving off radon.
Okay,
Okay, that's-
And it's from two specific minerals, and they both give off the radon.
okay. I hadn't heard
The
that.
minerals contain both thorium and uranium, but the thorium content is always higher
Interesting.
in both the granites and the metamorphic rocks.
Okay. So that would suggest that it's not just uranium, that if it were a correlation,
Right.
it wouldn't
Right.
necessarily give you the right
It's the combination.
information. Yeah, okay.
thorium is usually occurring in higher quantities than uranium.
Yes.
Can I ask about, in terms of the, getting back to the biomonitoring study?
Yes.
And the results that you get. So I had participated in the study, and we had, I think, talked on the phone about seeing eventually that you might be able to compare it, because it wasn't possible to see a well water result, like to compare my results to other people who are on private wells.
Right.
So it was just like other people could have been, city water that's already
Sure.
treated, other public water supply. Can you talk a little bit again about, or refresh my memory about how we might be able to compare apples to apples, about seeing private well
Sure.
results?
So I think what you're asking is if an individual participated in this study and they got, and I should say for all of your benefits, for the Biomonitoring Massachusetts study, when an individual participates in that study, they get provided to them essentially a booklet describing the levels of those analytes in their body with a description of what those levels mean compared to the US population, and a description of where those chemicals are historically found. So like I mentioned, high levels of mercury, we might say high levels of mercury are usually associated with eating a lot of fish. If you have high levels of thallium, is associated with certain vegetables, and go through that. So I think if your question is so the next step, so you have that result and it's comparing an individual to the national data, when might Massachusetts data be available where I can say, hey, this is my level, how do I compare to other people similar to me living in Massachusetts and are healthy,
On well water.
on well water.
Yeah.
And I'd say we're in the fifth year of a 5-year cycle of funding that essentially ends in August of this year, August 2019. We will be summarizing all of the data in a report, in an aggregate report, and that will be made publicly available like the USGS report. And what an individual would be able to do is look at that report, look for individuals of the same age, race, ethnicity, gender, and see how they compare to them. And then if we have enough individuals on private wells and enough individuals on municipal wells, would be able to do that kind of comparison. Yes?
So for the biomonitoring study, what, you have voluntary participants.
Correct.
You're doing the blood and the urine testing.
Correct.
What more are you doing as far as trying to understand what's contributing to those levels that you may or may not find in your blood? Are you well, we're talking about public or private water supply.
Yep.
Are you, as part of your program, do you test their wells also? Do you go through a history with them on,
Yep.
What they eat typically, or maybe, I guess you said, in the short term for the urine tests and that type of thing? Is that all part of the study so you can compare, what's real time, what's going on?
Absolutely, great question. So at a specimen collection event, which typically lasts about an hour, we will collect the specimens, the blood and urine, which you all know now. This is probably the most you've heard the words blood and urine at a public meeting in your life, so that's been beat into your heads. But at that meeting, there'll also be about a 45-minute questionnaire where there's about 45 different questions with multiple options. There's over 300 pieces of data on that questionnaire. And folks like Nicole has done a lot of them, if not close to all of them, sit down with participants and ask them about their diet, ask them about their occupation. And when we ask them about their diet, it's somewhat specific information. Nicole will take out a flip book and say, I see you eat rice, like how much servings of rice do you eat? This is a typical bowl of rice. Or you eat produce, how much produce? This is what a typical side of broccoli looks like. What's your occupation? What hobbies do you have? We go through a number of hobbies. So we're collecting all that information. So you're exactly right. When we're looking at all those data, we will look for ways to help explain why if we see certain individuals with high levels of molybdenum or high levels of cadmium, what in that questionnaire can help inform why those individuals had high levels. One of the other things we'll do with the aggregate report is be able to put it on a map, look at all of Massachusetts, and see what trends emerge. So we know about arsenic and uranium in this region just because individuals have mapped that and it's been known for some time. There's a lot of chemicals on there, for example, tungsten, thallium, molybdenum. Not a lot of information is known about what that looks like here in Massachusetts. So we'll put it all on a map and see if any trends emerge, either related to where people live or the jobs they have, the consumer products they use, things like that. Yes, sir.
So when you look at things like food, I'm thinking about farmers markets, particularly towns that don't have, public water supplies. When you irrigate with well water and the vegetables, I mean, from a toxicology perspective, do you see things like uranium or arsenic or other things on the list that aggregate, accumulate in the leaves of these? So people actually go to farmers markets in Harvard or something like that. Would they be at higher risk of actually getting higher levels of it by concentrated rather than drinking, from the...
Yeah, it's a great question. So what I would say specifically to this study, we don't have enough data from around the state to inform what Massachusetts looks like specifically. What I will say is that we do know that produce specifically has the potential to accumulate some of these metals and chemicals and can lead to elevated levels. For a lot of reasons, it's a good idea to eat a varied diet, right? Just to make sure you're getting all your nutrients, but also to vary the sourcing of that produce, to not always eat it from this specific area, because if you're only eating it from what's quite literally, if you only ate the produce that you grew in your backyard, you're constantly exposed to the same things in your soil that are in your backyard. I'll give you an example that got identified through biomonitoring, is that we identified an individual with a really high level of one of these specific analytes. It was thallium. And he had a level of thallium in his body that was essentially unheard of. So anyone that has a level above the 95th percentile, above a level that if we sampled 100 people, we would only expect 5 people to be higher than you. So if we find somebody that falls into that category, Nicole will call them up and say, hey, we're sending you your results in the mail, or did you get your results in the mail? They should have arrived yesterday or today. If you have any questions about your results, I'd like to offer you the opportunity to have a conversation with me. So this gentleman got scheduled for a phone call, and we started talking through the scenario, and he said to me, he goes, well, I start going through his questionnaire, and I said, well, I see you have a history of working in a metal shop. And I'm thinking, I solved it. I'm like a sleuth. Oh, it definitely explains your exposure to thallium. And he said, yeah, but I've been out of the shop for a while. I own the shop. I'm the boss. And he goes, I've been separated from that from a while. I haven't. I said, well, that's definitely not it. And he goes, it's been about 15 years. Can it stay in my body? And like I said to all you, no, it's not that. But he was because he was the boss, he was like, I usually go running every day, and he goes, I wasn't eating healthy. I was eating sandwiches and stuff. So what I did is I bought a big bag of broccoli, and I put it in the freezer. So every day, no matter, I still eat the sandwich. He goes, but instead of having chips now, I have a big bowl of broccoli. And I said, well, what's a big bowl of broccoli? And he described it. It was probably about 4 or 5 servings of broccoli every day, sourced from the bag of produce in the freezer that he got from a bulk distributor, but always bought the same produce and always ate a huge bag of it. So I said, general guidance is, generally speaking, it's a good idea to eat a varied diet. You are kind of doing the opposite. So I would recommend you don't do that, because high levels of thallium are associated with that kind of produce. He said, that's really interesting. Thanks a lot. And we had a conversation, and I made the same stupid joke with him that I did to you. I said, I'm not a doctor. I'm not trying to diagnose or treat a condition. I'm just talking through a potential solution to this. He goes, no, this is great. So he calls me back. He sends me a bunch of papers, and he goes, hey, I was looking into this some more. He goes, I took my broccoli, and I sent it to a lab to have it tested. And he goes, I had it tested for thallium, and the thallium levels were higher than the levels that are safe in soil. He goes, it's higher than contaminated soil. He goes, so then I called the store, and I said, where are you sourcing your food from? And it finds out they're sourcing it for a region in South America. And then I looked in the map, and it's an area, sure enough, with really high levels of thallium. And then I said, well, this is exactly how it's supposed to happen. Like, this is what happened. So the general answer to your question is, yeah, it's possible. I've seen it. I just haven't seen it in Massachusetts yet.
So just one quick follow-up. As far as just thinking about just the role of the state in toxicology, do you do things routinely outside of the biomonitor just for tests for, like, you know, environmental toxins? Let's use apples, for example. It was used as a pesticide, arsenic,
Yes.
for many years.
Yep.
And those orchards, you know, in the soil, you know,
That's
besides
right.
the bedrock, have tons of arsenic. So are there state resources so you can actually see, you know, where potential, you know, things like that have, you know, contamination?
Sure, there are routinely, and that's a great example.
That's
You
a
know,
good one. I was thinking about the
arsenicals
apple
and
picking last week.
copper. Yeah,
Arsenic.
exactly. That's a great example.
Yeah.
And
Or organic farming with copper, for example.
that's right, organic farming, right,
Right.
with
Mhm.
copper. So,
It stays there forever.
so I think there are systems in place. The Massachusetts Department of Public Health does not have a food surveillance testing program. So literally the answer to your question is no, but that is done at the federal level. So FDA and USDA team up to conduct testing. It's called the Market Basket Survey. So they have an intelligence gathering group that goes out and they sample food in different commodities from different regions around the country, and they put together this great list of levels of chemicals in all the foods we eat. Processed foods, they sample a lot of baby foods for obvious reasons, and then they sample all sorts of produce, and they make these beautiful tables and lists available with all that information. So quite literally, if you wanted to go on that list and see what levels of copper and arsenic and other potential heavy metals are in apples, you could see that. Is that
Or
useful?
You could pull it out by, say, Northeast region or state, or it's just going to be lumped into the U.S.
Depending on, for apples specifically from memory, I don't think you can. For things like pork bellies, you can for some reason. Like there's certain commodities where they identify that you can do that.
Depends on needs.
How well is purchased water monitored?
Purchased
By the
water,
United States, yeah, bottled water.
sure. So the Department of Public Health, that is squarely our responsibility. So I'd say bottled water is required to actually meet a different standard, whereas public water systems are monitored by the Department of Environmental Protection. Bottled water that's sold in vending machines or sold in retail establishments in Massachusetts must submit testing to the Department of Public Health, to our food protection program, to ensure that, one, it meets the minimum requirements for testing in Massachusetts for any public water system. And there's also some additional testing that we require in Massachusetts. And they all have to have certificates of analysis. So bottled water is both tested and monitored by the Food Protection Program.
How efficiently is that done?
Well,
Like us do.
I'm not aware of any deficiencies in the system.
We've run into situations where bottled water has stuff in it that it shouldn't have in it.
So, yes, ma'am.
Sorry.
problem.
So I understand that, is it true that you have like about another year left of this particular study, right?
Yes,
So my question is, what's the next study?
that's, we are in, because it's the last year, the way these things go, like it ends, that is a bright line. So the funding, you must spend all the money by August 31st. But what we're allowed to do is competitively reapply this year for more funding, and we're doing that. So starting late fall, early winter, we'll start a reapplication process to be submitted by early spring, and hopefully we'll get additional funding to expand the testing and do some additional work. Ideally, what we'd like to do is take the information we've learned in these first several years, once we have that report, and follow that line of investigation. So if we identify thallium as a real problem in certain vegetables or through individuals that have certain patterns, we want to follow that lead and try to see if it makes sense to recommend some new policy changes within the state to make sure that that doesn't happen. Yes?
Are there any differences in the way that in the methodologies or the thresholds in testing in children versus adults?
Generally speaking, yes. A level that is safe in a child is oftentimes lower than a level that is safe in an adult. I'll give you one just general example. We're really always concerned about lead in blood of children because it has the potential to really affect the developing neurological system, their ability of cognition, learning, memory. So we're really concerned about any bit of exposure while the brain is developing during that critical period of development between 0 and 5, and especially between 0 and 2. So that's a standard that we set really low. And currently in Massachusetts, we have set that standard at 3.5 micrograms per deciliter. We seek to protect the public with a really small level. Levels that adults that are working in industry, let's say you're working in a lead smelter or you were working in an area where it's known you're working with lead and you're monitored, that level could be almost 20 or 25 micrograms per deciliter. So it depends on how old you are and what the chemical is.
You mentioned if you have enough private well citizens and enough
Yeah.
public water, where do you stand now in having that? I mean, is a community like this underrepresented, overrepresented, about normal? Or?
It's a good question. I don't know what the breakdown of all, partly because it's tough to change the tire when you're going 1,000,000 miles down the Mass Pike, right? So we're kind of in the middle of this study, and it's a full court press to get as many individuals in the study, collect as much information as we can, and we're not simultaneously putting it into a database and crunching the numbers. We hope that through this process of statewide sampling, I'll tell you a little bit how we sample. There's a random digit dial survey that the state uses to reach people around the state. The whole country uses it. Every state administers a survey. And it's a survey used to inform general priorities like, should healthcare be changed in the country? And does the country generally have good coverage with their health plans? And is the country smoking more or smoking less? All those kind of questions. One of the things we've added to the survey is, would you like to participate in a biomonitoring study? And folks that answer yes to that question get enrolled in our study. So it's somewhat random in that way, in that we're reaching out to people around the state to get them into the study. So the reason I don't know your answer to your question is because it is random. I don't know where individuals are coming from. I do suspect at the end of the study, we will have individuals in Massachusetts from a representative amount of communities that have private wells. There's only so many communities in Massachusetts that have private wells. I can tell you right now, there are people in our database, in our study, that were sampled from communities with private wells. If we'll have enough depends on specifically what we're looking at, and the power to, or the ability to say something about that sample size. Yes?
If, when we have our lovely reporter here from the Carlisle Mosquito, which is our favorite hometown.
Love that name.
And
The Department of Public Health doesn't. They don't like mosquitoes.
If after people read this article, would there potentially be a case where we could have, if people are interested in doing it, something here at Town Hall where there could be, a dedicated day where, people could participate in the study, or is there still time to participate in the study, and would it be possible to do something in town?
Sure. The answer to that is yes. The study's still going on. We still have resources to partner with communities to do that kind of testing. If that was something that this municipality thought was worthwhile, you mentioned coming to, I'm not sure if you're referring to here, but literally come back here and do something like that. If that's something that the health department and the community wanted to make that request to the department, I suspect we would be able to accommodate that request. Likely, what we would do as we have different phases of this study. One of the phases that we're hoping to roll out here in the second half of this year, because as I mentioned, we're kind of trying to drive the car and change the tire and apply for the new grant, is we're going to do a remote urine collection protocol. So it would be less blood, because that's really intensive. You need certain, you need phlebotomists, you need certain equipment. But we'd have a system set up where we'd be able to mail kits to individuals in their home, mail the survey, they fill them out. And the collection would happen either through the mail, you'd mail it back to the department, you'd do it all in the convenience of your own home. Or another way we've done it in the past is you provide your samples to one specific drop box, one location. Staff would meet you at a single location. So those are options that we've done in the past, and I'd say both of those are on the table. Individuals can't always contact the DPH biomonitoring email address for more information or to enroll in the study, because what we will be doing is applying for new funding. At some point, we'll find out if we get it or not. And if we find out we have funding, then we will continue to collect urine and blood and all those other samples. So it could be that your request comes to the department at a time we're able to do the full panel. So it's a long-winded way of saying I'm happy to work with folks in the community if this is an ongoing request. Mindful that, you know, it's always difficult to go into a community like Carlisle, frankly, where you are certainly you're here because you're sensitive to the concerns about arsenic and uranium in water. And much like the people that participated in our original study, I think they got a great deal of relief from getting results back to them that showed the arsenic and uranium levels were non-detector low, and you all might find that same relief. And I'm not trying to judge that. You're free to make your own decision. But I want you to understand that that test is not going to tell you anything about intended health effects or if you were previously exposed or anything like that. So I want everyone just to go into it eyes wide open. Anything else? I've done a fair amount of public meetings. This is the best spread I've ever seen at a public meeting. It's great. Really feel welcome here.
Thank you so much for coming.
You're welcome. Happy to do it.